On today's episode, you'll hear two men talking about endometriosis. I recognize the optics of this, but this is a topic I haven't covered yet and an important one. So when today's expert approached the show with the idea to discuss endometriosis, I said absolutely yes. Dr. Laurence Orbuch completed his training at the New York Hospital Weill Cornell Medical College and SUNY Upstate Medical Center. He served as the director of minimally invasive and pelvic reconstructive surgery at the Mount Sinai Hospital and director of gynecologic robotic surgery at the Mount Sinai Beth Israel Hospital. Dr. Orbuch is currently clinical professor of obstetrics and gynecology at both Cedars Sinai Marina Del Rey Hospital and Providence St. John's Hospital in Los Angeles, and Lenox Hill Hospitals in New York. He is also the medical director of GYN Laparoscopic Associates LA in Beverly Hills, California. In his practice, he specializes in minimally invasive and robotic surgery for the treatment of endometriosis and all benign gynecologic conditions requiring surgical interventions. We talk about the pathophysiology of endometriosis, which was very surprising for me, how it typically presents, as well as some atypical presentations, which make more sense given his explanation for how it occurs. We talk about who is at higher risk, different conditions that may be caused or influenced by endometriosis, some misdiagnoses that may actually be endometriosis, and treatment options.
Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. Those on this podcast accept no liability for the outcomes of medical decisions based on this information. As the radiologists like to say, clinical correlation is required. This is not medical advice, and this does not constitute a physician-patient relationship. If you have a medical problem, seek medical attention. And now, here's Dr. Bradley Block.
Dr. Laurence Orbuch, thanks so much for being on the podcast.
Thank you, Brad, and thank you for having me on.
So we're going to be talking about something that I am probably not going to see very often as an otolaryngologist, right? We're going to be talking about endometriosis, but it's still something that I need to be aware of because I may get questions from family members or community members, you know, my kids' parents, kids' friends' parents, and the such. So I think it's important for every physician, whether or not they see it in the office, to be aware of it. So for those of us like myself who don't really remember much about endometriosis, can you just give us a brief refresher?
Certainly. And what's just as an aside, I've actually seen a few patients over the years who've required the services of an otolaryngologist because they had nasopharyngeal implants of endometriosis. And they would get catamenial, like nosebleeds, like massive nosebleeds, and end up in the ER frequently. And no one ever caught it until I had them worked up. That's just a fascinoma for the conversation.
How does that physiologically happen? We're jumping ahead here, but this is where the conversation's going.
I didn't want to forget, so that's why I brought it up. But let me kind of go back to the beginning and just share some general information. So the endometrium is the lining inside of the uterus that is shed every month when patients have their menses. Endometriosis is a condition where we find implants that resemble those cells outside the uterus. In the bad old days, the running theory, which was postulated by a general surgeon back in the 1920s named Dr. Sampson, was it occurred via retrograde menstruation, meaning that during a woman's period, some of the flow, instead of going out, was coming out retrograde back through the tubes and into the abdominal cavity. So, because he biopsied tissue when he was operating on patients, and then they looked at it under the microscope and it looked like endometrium. So that's where they came up with that. So it's the whole retrograde menstruation theory. That was subsequently disproved years later, but for some reason, people still cling to that theory because even amazingly enough, in many textbooks, medical textbooks, it's still in there as a one of, if not the main etiology of it getting there. So, but what we've discovered over the years in all the clinical case reports, there's pretty much the only organ or body cavity or space that it has not been reported in is the spleen. It's been found, like I said, in the nasopharynx, in the brain, thyroid, lungs, you name it, it's in the literature. So the etiology of it is really, it's thought to be more so multifactorial. And also there's a genetic component to it as well. I'll start off by explaining the genetic component. If it's approximately, if you have a first degree relative who has it, like mother, aunt, sister, grandmother, you yourself then have a 7 to 10 times greater chance of having endometriosis, and which is a huge predisposer to, to people being diagnosed with it. The most reasonable etiological pathway that's been found is that of metaplasia, that it occurs where during embryonic development, the mesoderm is the tissue, is the cell type that forms the urogenital tract. And as we all remember from embryology, most of us don't want to remember a lot of it, but because of a lot of the minutia and detail, there's migration of cells in order to form the different structures. And like, for example, like the paired organs, the urogenital sinus, it ascends and then splits and then forms both ureters, both kidneys, et cetera, and so forth. And the same thing with the uterus and tubes. And so in the process of that migration, there are cells that kind of get stuck in places that they shouldn't be. And then something triggers them to differentiate at some point, be it during embryonic development or after birth or after puberty, or it can get triggered at any time. There's even a study that was published in Italy just several years ago, where they did autopsies on female fetuses that were miscarried, and they found that 9-point-something%, a little over 9% of them, already had implants of endometriosis in the abdominal and pelvic cavity, which is very similar to the rate we see in the general population of roughly 10% of women have it. And then there are also factors such as environmental ones. We know that there's certain chemicals and toxins, like for example, dioxins, which are the byproduct of bleaching, in animal models have been shown to trigger the development of endometriosis. So there's components to it. Which one weighs more in the particular patient varies, the genetic component as well as the others. So that's essentially how it comes about. And it can be, it's usually more commonly, I should say, found in the abdomen and pelvis, because that's where, these cells tend to get stuck, so to speak, but they can be anywhere.
That makes sense due to proximity, right? Like
right.
That's just where they are going to go anyway. So they make it most of the way there, but not all of the way there. And they end up in the abdominal cavity as opposed to nasopharynx. Right?
Yeah. And that just as an analogy, we all remember, like from medical school, learning about dermoid cysts, in the ovary, and those cysts can have any kind of tissue in it. We find, you can find hair, teeth, brain, thyroid.
Yeah, differentiated tissue. Yeah.
Right. So it's along that same metaplastic process that these things come about. The problem is, unlike the endometrium, which is in the lining, which has an outflow tract to be expelled, these implants are, if they're on an internal organ or on the lining inside the abdominal cavity or wherever it is, it's confined to that place. And the same bleeding and release of inflammatory mediators like cytokines and interleukins and things of that sort that happens in the lining of the uterus and the endometrium happens in these implants, but it has nowhere to go. So each month there's this inflammation and bleeding and also irritation and triggering of nerve receptors, which then results in the symptoms that we find in these patients. The other thing that happens very frequently is that the symptoms are not just confined to the urogenital tract. So so it's not just painful periods or heavy periods. Because these implants are commonly in the abdominal cavity, the detrimental effects of the release of these substances affects the surrounding organs. So the whole GI tract, the urinary tract, because there's all this sensory nerve input, you then get upregulation of the entire central nervous system, because the pain signals, we all know, go from the peripheral nerve to the spinal cord up to the brain, processed, and then signals get sent back. So now you have this two-way discussion going on. And when pain lasts for more than 6 months, now it's in the chronic pain domain. And then you have this kind of diffusion of symptoms and this generalization or central sensitization, is what we call it, where you may start off with very pinpoint, like pelvic pain on one side, and then all of a sudden it becomes bilateral pain, and then it radiates to the lower back, and people have radiating, to their shoulder, to their neck, shooting pains down their legs, all kinds of seemingly unconnected symptoms, but they are connected because you now have your central nervous system involved in the whole process. So, and it can affect, it's more than just pain. So with chronic pain and upregulation of the central nervous system, people get anxiety and depression and disordered sleep, brain fog, loss of memory, forgetfulness. I mean, it really kind of blossoms over time the longer that it's in there. And then the GI symptoms, which are the most common non-gynecologic symptoms in endo patients, can be like bloating, constipation, diarrhea, food intolerances, nausea, you name it. And it usually sends them down the path of seeing their internist, who sends them to the GI doctor, who then does an upper endoscopy and a colonoscopy, and they find nothing, and then they diagnose them, they put them in that wastebasket diagnosis category of IBS, irritable bowel syndrome, which is really, it's just a description. It's not really getting to the root cause of why they're having irritable bowel syndrome. And the same thing with the urinary tract, because the GI and urinary tract are rich with the same receptors that the genital tract is, which are very sensitive to all these inflammatory mediators that are being released. So these things kind of tend to go hand in hand. And in younger patients, the most common thing we see, like even pre-puberty, is a lot of GI symptoms, stomach aches, motility issues.
Wait, pre-puberty?
Yeah.
How is that happening physiologically?
Yeah, because there is low-level activity of the of hormones even before puberty, and these implants are in places that they shouldn't be, so they're already working. They tend to then escalate, once they hit puberty, as more the ovarian function starts to increase, to full speed, so to speak. And the what we commonly see in a lot of these younger patients, when you start digging into their history, is that they used to miss days of school almost every month. The mother will tell you that they were curled up, in bed for like 24 or 48 hours, popping ibuprofen like M&Ms and Tylenol, and then they're, the classic picture is the mother then takes the daughter to her gynecologist, who then puts her on the birth control pill starting at age 11 or 12, and they've been on it now for 10 years, 15 years or more. And it's basically a pathway of like treating symptoms. People tend to think, well, it'll just get better, or then, the school nurse tells you, this is part of growing up, which it's not. Periods should not be debilitating, because a lot of these patients will then, they go off to college, and then they're missing classes in college, and they're always in the student health office, and then they get their first job, and they're calling in sick all the time, and they think at that point, it's been going on for so long, it's what I call the new normal. They don't think anything of it, and they just kind of, they revolve their lives around the limitations that are created by the symptoms from the endometriosis. And and it's really quite, debilitating, and it's really quite life altering. So the approach that I take is multifaceted. So obviously you want to get rid of the endometriosis.
Wait, hold on.
Yeah.
We're getting a little further away from, because I want to stay with presentations and symptoms before we get to management.
Right. Okay.
And so you mentioned that it sounds like our gastroenterology colleagues need to be aware of it. Our urology colleagues need to be aware of it because of those presentations. You mentioned back pain, right? That can be a symptom of endometriosis. But it seems like the clinical picture is concurrent with the menstrual cycle, right? And so that's going to be the giveaway. That's like, I get back pain once a month. I get these GI symptoms once a month. I get my urogenital problems once a month. Is that the case?
Yes and no. So there's both cyclical and acyclical related symptoms. And herein lies the problem, because most clinicians, even OBGYNs, are for some reason taught, if your symptoms are just, during your period, then it could be endometriosis, or it could be just you have bad periods. If you don't, and a lot of them then believe if your pain is outside of your period, then it can't be endometriosis. And it's not true. So it can be concurrent with their period. It could be outside their period. It could be during, the premenstrual part of their cycle, or it could be completely unrelated to anything revolving around that time of the month when they're having their period. And a lot of the coexisting symptoms, for example, like the back pain. So what ends up happening is when you have the chronic pain like this, and this constant, and this is how I describe it to patients, because it really kind of drives home the point. If you have acute pain, let's say you're cooking and you burn your finger on the stove, so you touch the hot stove, you quickly move your hand away. It burns, it hurts. You put some salve or ointment on it, and by the next morning, it's not throbbing anymore. If you touch it, it'll be sensitive, but it was an acute event. It heals and it goes away. Chronic pain, like endometriosis, is akin to putting your hand on that hot stove and just leaving it there. So you're getting these pain signals are just constantly coming, and it creates this sensory overload, which the other analogy that I use is like, it's like your car stereo. Like if you turn it on, halfway, it's music, it's pleasant, you enjoy it. If I turned it on full blast and left it there all the time, you would like lose your mind, and it would be overwhelming. And this is what's happening. You're overwhelming your central nervous system with pain signals. And when you have this constant feedback loop of sensory input and then response to it, you then end up with in neurology, they call it crosstalk between nerves. So these nerve roots come out of your spine. They continue to branch and they innervate different things. If it's in the pelvis and it's coming from the sacral nerve roots, what's going to happen? A lot of these sacral nerves are going to be communicated with and then trigger these other symptoms like lower back pain, in their bottom, pain shooting down their thighs. People have tingling in their toes. All these things that seem like so distant and unrelated are completely related. And what ends up happening with the chronic nature of the pain also is that it's not only the nerves, but then the muscles in the pelvic floor and the abdominal wall and the lower back are hypertonic, and they end up with what's called pelvic floor dysfunction and also dysfunction of the musculature in the general area. So the muscles are very tight. So now you have pain from these hypertonic muscles, and the problem is the pelvic floor is like a hammock of muscles that crisscross, and through that hammock of muscles run vital structures like the urethra, the vagina, and the rectum. So all those structures are in there, and they're getting squeezed. And anything that triggers, a contraction is going to tense up those muscles even more. And anything that triggers that a preemptive sense of more pain, like, oh, I'm going to have, I have painful bowel movements, I'm about to have a bowel movement, it's going to hurt, you're going to involuntarily tense up even more. Same thing with intercourse. Women have pain during intercourse. If you know it's going to hurt, what's going to happen? You're going to tense up. So these are other symptoms that come about.
We actually talked about that in an episode, quite a few episodes ago, the nocebo effect, right? The fact that you anticipate pain leads to more pain. So if you tell someone this is going to hurt, but basically that's an internal loop. The internal loop is telling them this is going to hurt.
Exactly. So you have to get them to unlearn that response while doing physical therapy, pelvic floor physical therapy, to help stretch and lengthen those muscles and stop that vicious cycle. The other thing, kind of going back to the GI issues, the inflammatory effect that it has on the bowel will then trigger like motility issues. So it tends to be slower motility, and classically what we'll see is like obstipation. It'll be constipation most of the month, and then when they get their period, then they get diarrhea, and then the whole thing resets again, and it's usually overflow from so much constipation. And what ends up happening in a lot of these patients is there's a high incidence of a condition called SIBO, S-I-B-O, small intestinal bacterial overgrowth. Because the motility is slowed down, the bacteria hangs out longer than it should, and you have overgrowth of bacteria in the bowel, because warm, moist place is a great growth medium for bacteria. And if, let's say, for argument's sake, normal colony count in your small bowel is 50 million, and you have overgrowth and yours is 100 million, what are you going to get? You're going to get bloating, because the byproduct of bacterial metabolism are gases and enzymes. So you're going to get a lot of gas and a lot of enzymes. So there's a lot of distension of the bowel, you get bloating. The enzymes then are very irritating. If it continues chronically, they end up with what's called leaky gut syndrome, where there's increased permeability through the bowel wall. And a lot of these inflammatory materials from the overgrowth then permeate through the bowel into the abdomen, and then that irritates everything that it comes in contact with, including the endometriosis. So it's this game of ping pong of like these conditions coming about. One's irritating the other, one's flaring up, it irritates the other condition, and it's back and forth.
So earlier you had mentioned that IBS is something that is a diagnosis commonly given to patients who ultimately could attribute their symptoms to endometriosis. Are there any other diagnoses out there that our patients may have that you would say actually more accurately you could attribute their symptoms to endometriosis?
Sure. So another condition that we commonly see is called interstitial cystitis. It's an inflammatory condition in the bladder, where there's a lining that coats the inside of the bladder. It's a protein coat that protects the bladder from any irritants in the urine from penetrating into the bladder wall. And there are different conditions that it's associated with, but we see it very frequently in endometriosis. And the symptoms are urgency, frequency, burning with urination, and it's exacerbated by foods that people eat that are very high in potassium or very acidic, and it tends to it mimics a lot of endo symptoms and kind of goes together with it. I mean, it's even referred to in the literature as the evil twin of endometriosis, and there's this triad of endometriosis, SIBO, and interstitial cystitis, or we call it IC, is a very common one. So I can tell you, I've been doing this for 24 years. My yield, for example, with SIBO, I'll send the patients to get tested for it. They do the lactulose breath test. It's a take-home kit that they get from their internist or gastroenterologist. And patients that I send to get worked up, probably more than 85% of them come back positive. That's how common it is. And the patients once, who with the bladder symptoms, I would say more than half of them, at the time of surgery, I'll do a cystoscopy to look in their bladder, and you can see telltale signs of it. There are inflammatory changes that you can see in the bladder. Easily more than half of them have some degree of that. So and that's why it's important to like work up all of the symptoms and all of the coexisting issues, because you'll never get the patient to feel as good as they can if you disregard a lot of these things. And unfortunately, there's a subset of physicians who feel that it's purely a surgical problem, and once you get rid of the endometriosis, wherever you land is where you're going to be, and that's it. And it's not true. You got to treat the GI symptoms. You have to treat the bladder symptoms. You have to treat the pelvic floor dysfunction. You have to address everything, because some of these things will improve when you get rid of the endometriosis, but something that's been going on for years or decades is not going to, there's no magic bullet that's going to get rid of everything. And the unfortunate reality is that in this country, I'm not talking about in the third world, the average delayed diagnosis is over 10 years. It's probably close to 12 years. And it's not hard to achieve that, because if you're starting to have, even if it starts when you're prepubescent or puberty, and you start having your period when you're 11 or 12, and now you're coming to see me when you're 25, boom, it's 13, 14 years. And a lot of people end up waiting even longer because they're told it's in your head, or it's part of growing up, and there's nothing to do about it. Take the birth control pill, get pregnant. That's another common one that people are told. Yeah.
That's the treatment strategy is get pregnant.
You cannot believe the things that I hear from patients that they were told by other clinicians.
Have a baby. Sure, everything will be okay. Just have a baby.
Right. So it's really, and that's where, unfortunately, there are not enough clinicians who understand this and who treat the entire patient. I always tell patients, I'm not here just to treat your pelvis. I don't have pelvic tunnel vision. You have many symptoms, and I can usually guess a lot of their symptoms. Like I can guess because they come in and they're very somber, and I can tell that they're tired because they're not sleeping well. They're anxious about all this. There's usually some depression and other mood issues. Many people they're on anti-anxiety medication, antidepressants. I mean, everyone's trying to plug a hole with medications or other treatments to treat symptoms, rather than stopping, looking at the big picture, and really addressing the whole issue and the global nature of what it can cause.
So aside from family history of endometriosis, because you said that's like 7 to 10 times more likely to have it if there's a family history.
Right.
Are there any other risk factors we should be looking for?
Unfortunately, we live in an industrial world, and I think the exposure to a lot of toxicity in the environment, and chemicals and
what do you mean? Do you mean like air pollution or
air, water,
UV radiation? I'm not sure what you're referring to.
It's in the air, it's in the water. There's radiation. I mean, there are hard and fast associations with certain chemicals. We know that because they've done testing on animal models, and they can trigger the development of endometriosis, with exposure to like dioxins and other things. But it's not we don't, the fact that we see so much of it. I mean, the incidence is well over 10%, which comes to close to 200 million women worldwide. So it's as common as diabetes, but it gets a fraction of the attention. I mean, that's changing slowly. There's more money now being put into research in the area of endometriosis, and clinical studies, and hopefully that the pendulum will swing considerably. And one of the things that I focus on is early diagnosis, because there have been multiple large studies done and multiple statements from the American College of OBGYN and other big governing agencies, emphasizing the importance of early detection, and that just because someone is a teen doesn't mean they can't have advanced disease, because they do. Is it less common than in an adult? Yes, but it still you can have deep infiltrating endometriosis in a 15-year-old. So there's no, and the one of the differences between endometriosis and a lot of other conditions, that there's no correlation to the amount of symptoms and the amount of findings. So you'll have patients who are very symptomatic, who have very pinpoint focal disease, and that's what's triggering all their symptoms. And then you have patients who have minimal symptoms, but their presenting issue is, yeah, I have some symptoms, but I've been trying to get pregnant for 5 years, and I've gone through 10 rounds of IVF, and nothing's happening, and that's why I'm here. And the really impressive statistic is that nearly 50% of what's called unexplained infertility. So the patient has had the $1 million workup with a reproductive endocrinologist. Hormones are normal, tubes are patent, the semen analysis is normal, everything's normal, they're ovulating, nothing's happening. Nearly half of those patients have endometriosis. And many of them, they don't think they have any symptoms until you really take a detailed history. My initial consults are an hour and a half plus, because I'm digging all the way back into the history when they were kids. And you really, when you bring up these things and you kind of point them out to people, and they realize that it's not normal, and yeah, I have more symptoms than I thought, it's very illuminating for them, and it's very telling. And unfortunately,
validating. Sounds validating.
Extreme, and that is the best word to describe it. And you beat me to the punch, because that's what almost every patient who comes in, and they have no idea what's going on. They've been told so many different things. They've seen 20 different doctors. You sit there and you get a full history from them. You explain to them what's going on and why it's going on, and why all these head to toe kind of symptoms are happening. And you see the light bulb go off in their heads, and many of them will literally start crying, and they're like, I'm not crying because I'm upset. I'm crying because now it makes sense to me, and I'm not losing my mind. And I've had patients who've told me that their therapists and psychiatrists have gotten fed up with them because they're always complaining, and they tell them it's in their head, because they have no idea what they're looking at. And rather than directing them to someone who can maybe figure it out, they invalidate what they're experiencing. They invalidate what they're feeling. And that's like, yeah.
So you had you said that the surgery to remove it is not the be all end all, and which makes me think you had also mentioned that they found endometrium implanted everywhere but the spleen. So let's say it's not in the abdominal cavity. Let's say it's somewhere else. Fine. It's in the nasopharynx. I can, cauterize that and ablate it probably, but that's it's in your nose, an easy place to get to. What about some of these other places that, and how do you even identify if it's there, right? Like you would do I'm probably using the wrong term, like an exploratory laparotomy, right? Or I guess laparoscopy.
Yeah, we do
to identify it. But what about in other places?
And so that's a great question. So the surgery is the cornerstone of treatment. I mean, you really, you want to get rid of what's causing all the problems. And just to digress a little bit, what I generally do for most people and most patients is I will start treating all their other coexisting pain generators as a lead up to surgery, because obviously, you're gonna, if you start feeling better, it's a positive psychological, factor, and it makes you feel better and stronger in preparation to going to have surgery, and then you continue all those things afterwards until everything is, resolved or mostly resolved. As far as what surgery you do, so I mean, what the old saying, when you hear hoofbeats, you think horses, not zebras. Most people have it intra-abdominally, so somewhere in their pelvis or their abdomen. And so laparoscopic surgery will identify that. if they have it elsewhere, there's usually other symptoms, like the nosebleeds, like patients who have it in their lungs have these spontaneous pneumothoraces, like canamedial pneumothoraces. They'll have a heavy bad period, and all of a sudden they have a collapsed lung, and they're in the ER getting a chest tube put in. You have a patient who's 20 years old and had a cerebral hemorrhage, and there's no aneurysm, there's no space occupying lesion like a tumor or whatever. Like, well, why is it happening? So you start scanning those areas to look, for the etiology of these things. So the more distant, odd kind of presentations are far less common, but they generally have related symptoms to those areas or organs or structures that would then make you suspicious of it. And when they already have it, you're already suspecting endometriosis, and it doesn't make sense that they're having these distant symptoms. Then you start working those things up, and
so you're not going to have someone with meningeal endometriosis that doesn't have significant disease in the abdomen.
Yeah, they're
right.
It's going to be in multiple locations, and usually
right. So they're going to be okay. So right. They're going to hopefully arrive at a diagnosis of endometriosis, and then carrying that diagnosis if they have issues in other places. Then that could lead you back.
And then other things, like some people will complain of like upper, like abdominal, almost thoracic, pain. So we look at the diaphragm when we do the surgery. Sometimes you can have diaphragmatic implants, and if they have other respiratory symptoms, you'll do a chest CT and have them see a cardiothoracic surgeon to work them up. And I work with I work with cardiothoracic surgeons, urologists, colorectal people, because of it can be in so many different places. You need to be prepared, for every possibility. And as you were saying, the surgery is laparoscopic, and surgery is another thing that there's the right way to do it, and there's the wrong way to do it. So doing ablation surgery where you burn it or laser it is associated with a higher recurrence rate, or more aptly, I think we should call it persistence rate, because
really, because I found lasers to be something that every patient's really looking for. If you can do it with lasers, they're going to have confidence in you. In fact, I want that to be the advertising campaign for my practice.
Right.
ENT and allergy, now more lasers. But you're saying no lasers.
But laser as a way to excise, or laser as a way to ablate. So some of us use laser instead of
lasers.
Yeah, some of us use it instead of scissors. I've done it with laser. I do it with scissors. It's really it's fine, but you're just using the laser to cut the tissue and remove the disease. What I'm talking about ablation is outright just burning the hell out of the tissue. And what I always describe it as is it's the tip of the iceberg phenomenon. What you're seeing is two-dimensional. It's the surface. You don't know how deep it is. You may have a 2 or 3 millimeter implant, but it may be 6 millimeters deep. And what happens if I just burn the surface? I'm just burning a little bit of the disease, creating scar tissue over it, and trapping the rest of the endo beneath the surface, which is going to continue to do its thing. And that's why if you look in the literature, the recurrence rate of endometriosis with ablation, where you burn it, is upwards of 35%, and all the excision studies, the rate is somewhere between 3 and 9%. So you're talking about like orders of magnitude difference, and the 5-year cure rate, if you will, is far greater with excision, as you can imagine, and because the recurrence rate is so much lower. And the problem is when people have ablative surgery, and then ultimately they end up having repeat surgeries, which more than a third end up needing it. Then there's distortion of anatomy. There's adhesions. It's much more difficult to completely excise all the disease. It's not impossible, but sometimes it becomes difficult when you have what's called an endometrioma, which is a cyst in the ovary full of endometriosis, and you have doctors who are following them for like years, and during that time they leak, they rupture, and now you have this stuff just oozing all over the place, and you have adhesions to the bowel, you have adhesions, to any and all surrounding structures, and it's like using a paintball gun in the abdomen and pelvis. You can't strip out everything. There's no way to get all of it out. So certain things are just not meant to be watched. And if it's an endometrioma, it's not going away. I mean, all that you can hope for is that it stays stable, but it more than likely is going to continue getting larger because every month you're having more and more bleeding and more accumulation of this material in there. So yeah, it's making the right diagnosis, doing the right surgery, treating all the coexisting pain generators and issues is key. And that's the step-by-step way to get the best possible outcome. There's no
treating all the pain generators. What do you mean by that?
I mean the upregulation of the central nervous system that's causing all these other pain symptoms: the back pain, the leg pain, the shoulder pain, the neck pain.
What kind of medication are you talking about?
So and that's a good question. So what we generally treat with are, so narcotics do nothing, as we know full well. It numbs your sensation of the pain, but the pain is still there and things are still as they were. You're just less aware of it. Medications like gabapentin and Lyrica help to kind of calm the central nervous system down, bring their pain threshold back to a more normal level, and that's systemically what we commonly use. Treating like the pelvic floor, we use compounded suppositories of medications like baclofen and Valium and things of that sort that we can use vaginally and rectally to directly get absorbed into the tissue and into the muscles to relax the muscles and also decrease inflammation. And that works great in conjunction with the physical therapy because you're working directly on rehabilitating the muscles, but you're also medicating them with pharmaceuticals that are going to help accelerate that healing process. So that's some of the ways that we approach treating the whole upregulated central nervous system. The SIBO is treated with antibiotics. Usually, the lactulose breath test checks for methane and hydrogen, which are generally elevated. One or both are elevated, and it's just a 2-week course of oral antibiotics, Xifaxan and neomycin, if it's both. If you had SIBO, you're much more likely to have recurrence of it. So if they have it again down the road, you just retreat them, and that then cools off all the inflammation in the bowel a lot. Because with all this inflammation, it's not only the bloating and the motility problems, but they generally have like malabsorption issues because there's so much inflammation in their small bowel, so they may be eating, but they're not really extracting from what they're eating all the nutrients that they need. There's also a high incidence of autoimmune diseases in endo patients. So many times we'll see them with autoimmune thyroid diseases like Hashimoto's, connective tissue disorders, things of that sort. There have been postulated theories of an autoimmune linkage of endometriosis, and that's why we see a lot of other autoimmune diseases, which I happen to agree with.
So, this has really been very informative about endometriosis, especially for an otolaryngologist who couldn't imagine that I'd ever see something. But now it's something that I'm going to need to keep in the back of my mind as a possibility for some of my patients. And a lot of our gastroenterology, general surgery, emergency department, internal medicine, obviously OB and urology. So many of our colleagues are going to have to keep this top of mind. As you mentioned, psychology, psychiatry are going to need to keep this in mind in terms of a possible diagnosis. So if we want to learn more about it or learn more about you, where do we find you?
So I have a website, and I have Instagram and Facebook accounts, so you can Google me and you can find all of those. And I post a lot of information, and whenever there's a lecture that I'm giving or anything that you can view online, those are also made available. And I am in California. My office is here in Los Angeles, actually in Beverly Hills. Those are the main, internet / social media outlets.
What are your handles on say Instagram?
It's at Dr. Larry Orbuch.
Okay.
And Facebook, you can just punch my name in. And then my website is lagyndoc.com. And there, there's a lot of information there about endometriosis, about how to treat endometriosis. I also use the most up-to-date modalities surgically. I use the Da Vinci Robotic platform because it's 3D high definition imaging, and also very, very wristed instrumentation. And it really, it gives you a lot more better resolution to see esoteric disease and more, less obvious things, as well as affording the instrumentation to do very, very fine and involved surgeries.
Wonderful. Well, thank you very much for your time. We really learned a lot.
Well, thank you, and I really appreciate you having me on the show, and I hope that we continue to spread the word and increase awareness, because I think that's key, and I'll keep doing everything that I can to achieve that.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.